Hello, everyone. Welcome to yours and my favorite part of the week. That's right, it's your online health psychology course, and I'm here to walk you through the hottest topics in information, communication, and health literacy. So, together this week, we are going to improve and become literate. With that said, let's jump right into it. Now, a lot of this information will go relatively fast because it's kind of just statements, beginning with what is health communication? Health communication refers to all interpersonal, organizational, or mass communication that concerns health. This can occur in various contexts, such as doctor-patient communication, public health campaigns as well, and it can be applied in a variety of settings, including clinics, schools, workplaces, and online communities. Continuing on, health communication can use a variety of channels, including face-to-face communication, posters, and various social media posts. And the messages vary depending on the campaign. They can include, for example, healthy eating, smoking cessation, and safe sex. And they can serve a variety of purposes, such as risk assessment, communication of diagnosis, service awareness, and advocacy. So again, kind of all straightforward here. Just health communication referring to all forms of communication across a given society, taking various forms, both online and personal, or like a billboard kind of situation like that. And this can be include, I should a variety of settings because depending on the condition or whatever health outcome you're trying to improve, obviously some people are going to be targeted and thus some locations are going to be specifically targeted. Like, for example, we want to stop teen vaping or something. You're probably going to target that campaign in schools or something along that, or the internet or parents, something along those lines. But you're not always looking for or advocating for a particular position, like stop vaping or something like that. Sometimes you want to get a better idea of the rates of a particular behavior. So how often are people vaping? How often are people engaging in unsafe sex? Which then could be used for subsequent campaigns for targeted intervention purposes, for example. We do have a model of health communication from Shannon and Weaver in 1949. I hope you're both with us still, Shannon and Weaver. This is one of the best known and longest lasting models of communication. There are 5 components, beginning with source, that is where the message is coming from. The transmitter, that is something that encodes the message into signals. The channel, where encoded signals are transmitted. The receiver, something that decodes the signal back into the message, and destination, where the message goes. So for our purposes, we really don't have to focus that much on this encoding aspect here, but the 3 components that we are going to look at here, just source, receiver, source, channel, and destination. Source, again, who it's coming from, so medical professional, teacher, I don't know, a celebrity, your favorite TV celebrity. And then channel, just kind of the method by which the message is communicated, so internet, whatever. And destination, where the message goes, / who receives the message. So in our case, the teen vaping example, theoretically teens would receive would be where the message, who receives that message, and whatever, maybe they wherever they receive it from, their smartphone or their teacher or something like that. Now let's jump into our first kind of real construct here, healthcare professional patient communication. A classic study by Byrne and Long in 1976 identified different doctor styles of communicating with patients. This was based off audio tape interactions from 71 GPs, about approximately 2,500 patients. What the researchers did was identify 4 diagnostic styles, that is, clusters of behaviors, and 7 prescriptive styles used by doctors. The styles constituted a continuum from patient-centered to doctor-centered styles. Patient-centered communication style makes use of the patient's knowledge and experience through techniques such as silence, listening, and reflection, while doctor-centered communication style makes use of the doctor's knowledge and skill with minimum input from the patient. As I'm sure most of you are familiar with, the idea of parenting styles, like any kind of style, doctor style, whatever here, it's just, again, kind of a clusters of behaviors. So certain styles are expected to demonstrate certain behaviors, and you can test this statistically. So in our case here with our doctor styles, we have, or I should say, doctor styles of communications. We kind of have two endpoints of our scale. On the one hand, we have patient-centered, and the other end, we have doctor-centered, and you can fall on that continuum. Just with 100 being doctor-centered, 0 being patient-centered. I'm just making this up. And you're going to fall on that scale somewhere. But the closer you are to 100, the more you are operating from a quote-unquote doctor-centered style. Again, a cluster, a collection of behaviors that are associated with this particular style. And kind of the two poles are fairly self-evident. We're patient-centered, meaning that you are the practitioner is leveraging the patient's maybe expertise, their knowledge of their particular community, their knowledge of themselves, just kind of an understanding that a patient is bringing experience, knowledge to the table. Versus, and this is really not a versus because it's a continuum and you're going to fall on the scale, but for the purposes of colloquialism, versus doctor-centered communication, wherein kind of a greater priority on the doctor's knowledge, background, and education, their experience, and whatever medical procedure or health-related behavior is being assessed or intervened on, and thus, because the doctor's expertise is being prioritized, depending on where that scale, we'll just say 100, say you're a pure 100, you're pure doctor-centered. In that case, boom, all you care about is your own expertise, and you do not care about or have very little concern about the patient's opinion. But obviously, most people are not going to fall at 0, 100. You're going to fall somewhere in between. And then kind of the idea is like pairing styles, you can do an experiment or measuring does a specific doctor style of communication, is that predictive of higher rates of adherence to a treatment plan or continued visits to a doctor's office, following through with that intervention in the long run is kind of the idea here. Using leadership theory, Hun and Sweeney updated these communication styles and outlined 3 pattern approaches to patient care among clinicians. So basically, they took those kind of older styles and then and updated it with new experiments and new statistical analysis and interpreted it through this idea of leadership theory. Leadership theory, broadly speaking, is like what makes a good leader, like what behaviors are associated with good leadership, values, and all these other things. So ultimately, they came to 3 patterns of how medical professionals interact with patients. So different kind of approaches to patient care. The first one, laissez-faire, negligent and unsympathetic towards patients, fail to interfere until my health issues become serious, avoids making decisions with regard to my health. So this is kind of like, think of like economics here, kind of more of a hands-off approach, which can at times get approach the limits of like negligence. So kind of max letting like, let them handle it kind of situation until it's like a very, very, very serious problem. And then it's like, okay, well, now we have to do like, I don't know, I'm just making up something here, surgery or something like that. So kind of being almost like, again, relating back to parenting styles here, being like an absent parent or something, a negligent parent. Which could not always maybe be related to maybe an unsympathetic orientation towards a patient. So kind of like, this person is like screwed. They're not going to listen to me anyway. This person's always screwing up. You know what? You want to do that? Go do it. Go figure it out kind of thing. And then go, you made your bed, go lay in it. It's kind of a general orientation here. Next, we have transactional. In transactional patient communication style, a practitioner sets health goals and provides patients with instructions, feedback, and reinforcement to pursue behavioral goals. For example, a clinician/patient transaction may begin with a description of a health plan during an initial visit, such as an exercise regime and medications, and end when the clinician provides feedback regarding the patient's success or failure in executing the plan during a follow-up appointment. a common quote describing this kind of form, this kind of style, would be makes clear that I can expect to receive, or makes clear what I can expect to receive when health goals are achieved, directs my attention towards failures to meet standards set for my health. So here now we have kind of a much more bidirectional relationship between a clinician and a patient, wherein the clinician is setting goals and providing kind of like feedback in real time, like, okay, this amount of exercise is insufficient, or this amount of exercise is sufficient, or you should be taking this medication at this time, not this time. And so kind of a much more communicative bidirectional approach here, with the goal being that you want both clinician and patient want to improve the health outcomes of the patient, and this is done really kind of through looking at kind of goal-directed behavior. So kind of like you have your goal in mind, these particular behaviors are improving your chances of meeting that goal. These particular behaviors are not, and kind of, again, working through this kind of iterative bidirectional process, bidirectional meaning between the patient and clinician, to, again, make sure that the patient can increase the probability of improved health outcomes. So much more of a hands-on approach. Next, we have transformational. Here, clinicians provide health goals, and they inspire and motivate patients to be personally engaged in those goals. Hun, in 2016, suggested that the transformational patient care style is the strongest positive predictor of patient satisfaction and health expectations. Quote, get me to look at my health problems from many different angles, and expresses confidence that my health goals will be achieved. Idealized influence, inspirational motivation, intellectual stimulation, and individualized considerations are prioritized in this style. Components are not mutually exclusive, however. Clinicians can engage in any or all these components in order to maximize their effectiveness as care providers. Transformational and transactional styles are not necessarily independent of each other. Rather, the transformational style enhances the effects of the transactional style, Hun argues. Transformational clinicians are effective because they transcend transactional behaviors, not because they neglect transactional behaviors. So here we have much more of so maybe a social dynamic going on here, maybe more of kind of like an intimate and kind of like the purest form of that term. So kind of a social desire, a social connection here between patient and the clinician, rooted in trying to, again, improve health outcomes. But one additional method which differentiates transformational to transactional, again, communication styles, is this emphasis on motivation and inspiration, as well as a bit more flexibility. So kind of you're kind of building that social bond, and you're helping a patient look at their health behaviors, their health problems from many different angles in kind of a collaborative way to attempt to increase the probability that that patient kind of fully understands the stakes at hand and is ultimately kind of meeting the patient where they are. So kind of identifying their kind of expertise, their hashtag lived experience, and all that good stuff, and kind of working with them to connect their health goals that is laid out within a clinical setting to kind of the real world, how it impacts them in the real world, how these behaviors can be translated to the real world, and again, kind of building, gassing them up a little bit, expressing confidence that their health goals can be achieved. So thus, it's kind of the transactional model, but with more of a kind of like active, pro-social message, rooted possibly in a greater social understanding, empathy, and collaboration with the patient. There are direct and indirect pathways that link effective communication with health outcomes. Direct paths highlight benefits related to improved survival and remission rates, enhance emotional well-being, pain control, functional ability, vitality, and reduce suffering. Good communication may also facilitate better healthcare professional/patient relationships, which can improve intermediate outcomes, such as access to care, treatment adherence, self-management, support, and trust in the healthcare system. This is an indirect effect. So to pause momentarily to explain the difference between direct and indirect effect, direct effect is, as suggested, direct. So I punch you in the face, boom, pain. Okay, that's a direct effect. My fist into your face, direct effect. Okay, my fist in your face, you feel sad. Now, an indirect effect, for example, there's research that suggests that being fired from your job or kind of economic precarity or uncertainty within your job, increasing the risk of divorce. Okay, so that correlation between unemployment or economic precarity and divorce is not direct. It's not like your boss who fires you says, okay, now you have to go home and divorce your wife or husband. No, rather that firing or that reduction in hours is going to increase the stress of that worker, which likely is going to bring that stress home with them, and that can increase instability within the household through maybe less money to pay for the bills, less money to go out on dates, just greater like stress, so then like rough communication. So these things are all kind of like indirect effects, indirect ways through which being fired increases the probability of divorce. So again, it's not your boss saying you must now go home and divorce your wife. It is kind of these indirect pathways that increase the probability of divorce. So kind of the same thing here. We have direct pathways by which communication impacts health outcomes, and indirect pathways by which healthcare professional patient communications impacts patient health outcomes. So for example, a direct pathway, say I'm a doctor and I'm like, okay, take this medication that you need to live every single day at 8 p.m. and you'll be fine. Well, now that I've given you that information, you can now take that medication and you will survive. You will improve your survival odds. That is a direct effect, kind of the idea. Again, I gave you information. You're now going to take that information, take the necessary medication at 8 p.m. every single day. Boom, you're alive. Way to go. We did it. Now, an indirect effect, so something like, get a positive communication style. So we'll just go with transformational or transactional, doesn't matter. So we'll say, so there's a positive, ultimately, patient clinician relationship. And then all of a sudden the patient's like, you know what? This healthcare industry, maybe they're not so bad. These doctors aren't trying to kill me right now. And I feel good. I like this doctor. You know what? Maybe I'm going to start coming to my checkups after all. I'm going to come to these follow-up visits. Why am I going to come to those follow-up visits? Because now I trust in the healthcare system more. I believe I'm less alienated from healthcare. I believe in this person. Therefore, that trust, again, is going to increase the probability that I'm going to come back to the doctor's office for follow-up appointments, communicate any kind of issues that may arise during this treatment, and now I've increased the probability of my survival. So again, indirect, you've established a positive relationship, you've built a person's trust up in that relationship, and which could bleed over to like a wider, greater trust in the system, which then is linked to adhering to their medication, their intervention, engaging in follow-up visits, which then is correlated with increased rates of survival. So those are indirect effects of healthcare professional patient communication. So make sure you know the difference. Therapeutic alliance. Term often been confined to psychological interventions. The changing dynamics in HCP patient interactions, however, has led to the emergence of the idea of a therapeutic relationship between HCPs and patients with physical illnesses. Patient-centered communication has strong positive associations with the concepts of therapeutic alliance, a term used to describe the relationship between mental health practitioners and their clients. Argued that when HCPs listens to what patients have to say, ask questions, and show sensitivity to their emotional concerns, the therapeutic alliance is strengthened. Evidence from a systematic review in 2010 suggests that having a good therapeutic alliance between HCPs and patients can positively influence treatment outcomes through improvements in symptoms and general health status. So, like everything in psychology, there are multiple constructs that describe similar phenomenon in often kind of overlapping ways. Here, again, kind of consistent with the idea here that there is a relationship between HCPs and patients, and that relationship can impact health outcomes in the patient. So here, kind of taking a term, I would say traditionally, not necessarily, but we'll just say traditionally, which I'm not a big fan of the term, but whatever. Traditionally confined to psychological interventions, so between like a therapist and a client, then that kind of relationships, for kind of relatively self-evident reasons are going to impact, whatever it is that's being worked on in this therapeutic session. Well, this is extended to physical illnesses or other chronic physical disorders, with more or less kind of the same principles that, well, this is a social relationship, and the quality of a social relationship can impact if you're going to listen to that person, if you trust that person, and thus are you going to adhere to whatever intervention or change in lifestyle, or at least attempt to do so. So kind of like all things, HCP patient interactions are a social relationship. We are a species of social relationships, and those social relationships can impact our particular behaviors, and in this case, our health outcomes. E-health and M-health. E-health is a general term referring to the application of digital technology, such as the internet and digital gaming, to health promotion, treatment, and care. M-health refers to the use of mobile and wireless applications, SMS, texting for our non-Europeans, apps, wearable devices, remote sensing, and use of social media to health-related purposes. So obviously these two constructs, the line of demarcation here is going to be a little bit blurry, but for just general purposes, M-health, we have just mobile, like your cell phone or something along those lines, versus e-health maybe just being more browser, internet, which obviously you can access on your phone, but I don't know, think of an old person using a computer or something like that, or gaming. Ultimately, though, to improve health outcomes. So now we have kind of different means in which that we can try and improve health outcomes through the hashtag the internet, gaming, texts, apps, your phone, all that good stuff, / all that bad stuff. In spite of health information being widely available online, HCPs generally are still seen as the main sources of reliable information by patients / service users. Susie Dell-Light in 2012 found that people who use eHealth tend to consult HCPs more often than people who don't, especially among those who have good health care coverage. Chung in 2013 found that men were more likely than women to have conversations about information found on the internet with HCPs. Ironically, those who had trouble understanding or trusting online health information were found to be no more likely to ask questions or seek guidance from HCPs. So it's attempting to interpret some of these findings. We have HCPs generally still being seen as the main sources of reliable information for a lot of reasons that most of us have already experienced in our lives. You Google your symptoms or whatever, and you get like a wide range of diagnosis, and ultimately you have no idea which one you are because it's going to be based on things that you can't test at home, expertise that you don't have, and whatever the particular life history of yourself and or your family. So thus, although this information is available, it is difficult to kind of disentangle what it is you have due to numerous counterexamples and kind of just the peculiarities of a particular person's health history. And moving on to Susie Dell-Light finding, this could be that people who use eHealth tend to consult HCPs more often. So this could be a person who's just like, they got to have the information. So the more information is good. They're looking up things on their own time. They're consulting. They're very much going to be involved in their health intervention or just kind of health status or daily health behaviors. So these people are just doing more. So in this case here, it's not replacing, or I should say eHealth is not replacing, HCP consultation, but rather is supplemental, getting more information for your neuroses or whatever, or just, people want to learn more about themselves or something along those lines. And the good healthcare coverage is kind of straightforward, wherein if you have good health care insurance, you're more likely to consult your HCPs because you probably have an actually assigned primary doctor. You have, and it costs you less money. I would not know about that because I don't think I've ever had a primary doctor, but we can dare to dream, folks. And then our final bullet point, there can be multiple interpretations that needs a deeper dive in the research that I am not going to do right now. To the extent that we have a conclusive answer, there's going to be some variation here. So this could be, again, so we have the finding that people who have trouble understanding or trusting online health information found to be no more likely to ask questions or seek guidance from HCPs. This can go a multiple direction. It could be a person who's like, okay, well, I tried to figure this out on my own. I have no idea what the hell this says or what I'm supposed to do. I don't know. I'll leave it to the healthcare professional. I'm not going to fall. They're going to tell me what to do, and I'm going to do it. Boom. I'm done with that. I tried. I give up. The end. Or it could be a person who tried to look up something, and they are just pretending they know and understand it, and they're kind of insecure about, I don't know, expressing their uncertainty or something along those lines. Or this obviously can also have gendered effects. So there's going to be some variation, but those are a few possible ways of interpreting the results. Again, interpretation can go many ways because there's multiple ways that you can interpret a specific finding, especially an isolated finding. You need to kind of read a lot of the specifics of the literature to come to a stronger, more confident conclusions. But even then, there's going to be disagreements because there's different theoretical ways to interpret things based on your kind of school of thought. Online interventions are also being developed for health-related purposes. Recent studies have shown how internet-based physical activity can increase self-efficacy to exercise and reduce the likelihood of indoor tanning use. Innovative mobile apps are also being developed to support self-management of chronic conditions. So we have some findings that suggest some improvements and things associated with health outcomes, such as self-efficacy. Again, that you believe that your belief in your ability to accomplish a goal, basically. And here, the likelihood of indoor tanning use. But also, I should say, as kind of caveat, some research has found that these apps can have no effect or actually have a negative effect on people for a whole host of reasons. There was actually a recent I don't know, last couple of years, lose track of time. And basically by me saying the last couple of years is meaningless because I'm going to use this into the future of this video. But whatever, doesn't matter. So I don't know, around 2020, 2022, 21, whatever it was, that found that, one of those mental health apps or therapy apps situation was actually composed of basically a lot of bots. You weren't really talking with a real person. And those patient outcomes were not good. So that's just kind of one scenario where it's just kind of, this is a little bit foul play, unethical situation going on here because that was not disclosed beforehand. Also, there's a whole host of other reasons. One, variation, specifically talking about kind of like mental health kind of thing. The variation in the quality of mental health quote unquote professionals with the master's degrees is just massive. I mean, it goes from just like totally awful to like pretty solid and good. And then ultimately, also another possible critique is that you're basically just increasing the amount of time you're spending online and on your phone, looking at your phone, which considering the rates of phone use especially for younger adults and in general across the U.S. really could be actually kind of a negative thing. So just making someone even more attached to their phone and chronically checking notifications and establishing new other parasocial relationships through a phone could also not be great. So greater accessibility possibly, but maybe with downfalls of all things related to negative effects associated with like phone use, especially for younger adults. So what to do about that? Navigating that, if that method is kind of recommended moving forward, kind of up in the air depending on your theoretical perspective. Online platforms are widely used to share health data. In a qualitative study of an internet forum for patients with lupus, Mazzoni and Kaikonani in 2014 found that participants post messages online to start new relationships, seek information, receive emotional support, and contribute to discussion. Chu and Hosea in 2013 also found that writing online blogs enabled cancer patients to reconstruct their life story, express disclosure of life, and hope they will be remembered after their death. Reading other patients' stories also influence their own experiences of living with cancer. Sometimes other patients influence their perceptions of their prognosis more than their doctor. So this is basically more or less a classic like forum/message board, depending on how old you are, finding wherein people with either similar interests or in this case similar health conditions gather together to form kind of social bonds. In this case here, in this study in 2014, people with lupus making friends with other people who also have lupus, and then you have the opportunity to kind of like share your experiences, what works for you, what doesn't work, or find kind of social support and emotional support in these discussions, and then kind of general kind of discussion. In the blogs, kind of similar idea here. Blogs allow you to tell your story, something along those lines. So in this case here, in the Chu study in 2013, we have cancer patients using blogs as a way to reconstruct their life story. So we all kind of have like a life story, and this kind of cancer kind of or blogging opportunity allows a person to kind of express themselves, kind of orient their this new cancer diagnosis with their earlier life, and try and figure out, how to go from there. But as well, kind of seek closure of life, or and how they want to be remembered after their death. So kind of writing, kind of leave like this legacy. Kind of people in general like being, even in the West where it's a little less emphasized, it's kind of a feature of humanity. I think kind of uncontroversially that people are concerned about kind of the intergenerational like connections, where they fit in kind of the grander scheme of the world. Now, the evaluation of that will differ for a whole host of reasons, but in general, that interconnection between living and dead and life history and all these kind of things are meaningful to people. Now, there's also some research that has found that forums can be kind of negative. So, for example, often there will be kind of like tropes associated with certain like health. So, for example, this idea that you have to like think positive. If you think positive, that'll increase your health outcomes. If you think negative, then you are decreasing the probability of recovery or something along those lines. Therefore, it's your fault. You need to think harder. You need to go more positive. You need to do X, Y, Z. Just do all these things, behaviors, make all these behavioral shifts, make the whole host of cognitive and emotional shifts, and then you'll be healthy. Well, if you kind of, there's some research, a case study in which a person who had cancer really did not take that kind of view and was like, this is all kind of like hokum. It doesn't matter if I think my life-threatening cancer is good or bad. It doesn't matter. It's cancer. It doesn't care. So I just want to just kind of rant a little bit about it and whatever. And that person was kind of met with scorn by other people who kind of adhered to that idea of like, you got to think healthy or something like that. Which in return can kind of like isolate you even more. Like, oh my gosh, like these people that I was seeking support from who have similar condition as me now are like saying it's my fault, or kind of like boot me from the group, something along those lines. Although the internet can provide opportunities for health promotion, there are some occasions wherein maladaptive health behaviors can be encouraged. And as you should know by now, maladaptive, researchers just throw that term around to mean bad. Does it actually mean that? Debated. But we're rolling with the wording that's given to us. So bad health behaviors, negative health behaviors can be encouraged. For example, the internet is full of posts related to, quote, Fitspiration, which is usually an image with a quote that motivates someone to exercise hard. Bopple and their friends in 2016 conducted a content analysis of Fitspiration websites and found that majority of the websites promoted excessive exercise and dietary restraint for appearance-motivated reasons. So here we have this construct Fitspiration, wherein this author is operationally defining it as kind of a maladaptive health behavior / like negative health behavior. So the idea being that in exercise, good in general. Ooh, we love exercise / I hate cardio, but if you love it, God bless. You're What a blessing. But anyway, so exercise, yes, great. However, kind of excessive exercise, and not just excessive exercise, but how do you evaluate that exercise? So that could be body shape, dietary restrictions, which again could be positive. Can't eat a carton of ice cream every day. But kind of the idea is that it can go too far. It's excessive. So this can contribute to body image issues like pro-anasites, all that kind of stuff, or increase the probability of, or at least socially support eating disorder related behaviors. But really kind of overall, just kind of a general a quote of someone exercising, and then the most vapid, lacking substance, quote under it, would basically saying I'm trying to motivate you to, go hard in your exercise routine. Simpson and Mazzeo in 2016 reported that Fitspiration messages on Pinterest encouraged idealized body image standards and included comparable amounts of fit praise, such as an emphasis on toned physique, and thin praise, emphasis on thinness. While Holland and Tigerman in 2016 found that women who post Fitspiration images on Instagram are more susceptible to unhealthy eating and exercise groups than those in a control group. So we have Pinterest here, which, if you read in 2014, guys, it may not be looking good. They're facing into bankrupt. So we'll see what happens. But in the meantime, while we are all decorating creating our boards and decorating our house or whatever, in this study, these researchers found that Fitspiration messages on Pinterest was associated with idealized body image standards, and an increased emphasis on thinness, which again can be a pathway, or at least supportive of a negative body image, and increased probability of eating disorder behaviors. And then we have our second 2016 study, wherein women who posted Fitspiration images on Instagram more susceptible to unhealthy eating. So this is kind of a classic correlation does not equal causation situation. So it may not necessarily mean that if you post an image on Instagram about Fitspiration that causes you to engage in more susceptible eating, but rather maybe people who are already prone to unhealthy eating, or maybe some skepticism about their body, maybe then start just general Googling, and then they come across these kind of ideas about excessive exercise or unhealthy thinness. And then they kind of get into it, and then they're like, okay, I support this. I'm going to post it. So now those person who are already susceptible to unhealthy eating and exercise behavior, then posting. But ultimately, though, people who are engaging and posting these particular Fitspiration images wherein excessive exercise and excessive thinness are encouraged, those people this research found that those people are at greater risk of unhealthy eating and excessive exercise behaviors than those people who do not post those types of images on Instagram. Systematic review in 2013 found that mobile phone messaging reminders can improve attendance in healthcare appointments. Another systematic review by Rothert in 2017 showed that although the use of electronic health records, EHR, can improve documentation and sharing of biomedical information, it may interfere with doctor-patient communication, development of supportive healing relationships. Allowing patients to access electronic health records could potentially improve doctor-patient communication, patient empowerment, participation in self-care. It's argued that ERs must be developed to capture useful data without interfering with physicians' and patients' abilities to effectively communicate. So kind of our first systematic review here of message reminders, kind of straightforward. As someone who forgets things quite often, that reminder that, oh yeah, I'm supposed to be doing that today for a reservation, for example, is like, oh yeah, I should do that. So kind of straightforward here. A simple reminder, so if you forget, but also maybe kind of just keeping motivation high among a person, make a schedule a doctor's appointment a month from now, and then it shows up and you're like, I don't really want to do this, but maybe the kind of frequent communication kind of maintains that kind of social connection to that person, and then they're possibly more likely to show up for their healthcare appointments. And then we have electronic health records. Kind of the balance here is that having documentation, sharing medical information for patients, which could have improve access of the patient to their health care related information, which may allow them increase the probability of them adhering to whatever treatment is because they can keep accessing and checking it out. They can feel more empowered and self-sufficient because, again, they can check these records, have ongoing information that can suggest to them that they know what's going on, their health literacy is high, and they're they believe that they can continue to adhere to whatever recommendations are being suggested. And then the concern is basically using electronic records to completely just replace person-to-person communication, which can make a healthcare professional kind of more abstract and more maybe transactional in nature, not from the style, but kind of I purchased something and now I'm going to receive something, which can really fundamentally shift the way that the relationship is perceived by a care patient. Because if I'm just buying something as a service, well, that person is just a business and that person doesn't care about me at all and I don't care about them at all. So it's kind of a different, maybe asocial dynamic, which can be potentially harmful to the development of supportive healing relationships between patients and a healthcare professional. Use of e-health interventions can promote positive health literacy outcomes in a variety of contexts, chronic conditions, and diverse populations. There is a risk, however, of widening social and health inequalities if care is not taken. Interventions delivered via technology should provide culturally relevant health information and decision support to consumers with lower literacy. Since those with limited health literacy skills tend to have limited access to the internet, these groups may become even more marginalized as health and social care services become more digitalized. So kind of concern is, obviously, you can get greater access to information, but the groups who are at greater risk in general have lower rates of technology access, or the technology they do have is more limited. So maybe you have a shittier cell phone plan, so they have less coverage, maybe just less data or something along those lines on the internet or on their phone, maybe a slower internet speed, maybe they don't have internet speed. There are millions of people that basically have no/very extremely slow internet speeds. So moving everything online could contribute to widening those already social and health inequalities among those groups in particular. Moreover, because it's online and maybe there's somebody just creates a generalized form of health information, maybe that generalized form is not realistic or applicable to particular traditionally disenfranchised groups or cultural minority groups across various forms. We've talked about this in the previous chapter, that recommendation must be kind of grounded in the lived reality of a person, and be consistent with their kind of cultural values. So kind of a universal single template, theoretically, on a web page or something along those lines, may be insufficient because they do not cover the cultural dynamics of a given population within a country. Message framing. The way messages are framed influences people's intention and willingness to change their behavior. Examples of loss-framed A and gain-framed B messages for smoking cessation to the right. So looking at the example here, loss-framed in regards to smoking, you see that it's much more you will lose something. Something bad will happen to you. So we have lung cancer, increases your risk of heart disease, chronic bronchitis, versus B, kind of gain-framed, that is, what do you gain by quitting smoking? And that is, your lungs will be healthier, you'll breathe easier, you'll feel healthier, whatever. So ultimately, it's loss versus a kind of a gain frame here in this binary framework. Elaborating a bit more, gain frame messages give information about a health behavior that emphasize the benefits of taking action, while loss frame messages give information that emphasizes the cost of failing to take action. So in the previous slide, we had gain, that is emphasizing the benefits of taking action, healthier lungs, breathing easier, versus loss frame, the cost of failing to take action, that is lung cancer or something along those lines, heart disease. Updegraff and Rothman in 2013 identified two major approaches in message framing research. that is exploring the perceived risks and uncertainties of the health behavior, and exploring the motivation of the recipient. Both the perceived effectiveness of behavior and perceived susceptibility to and severity of health risk can moderate the effects of message framing. So kind of the idea here is message framing can be impacted by the perceived effectiveness of a behavior. So if you believe that the intervention or the medication or whatever you're being asked to do is effective, that can impact which framing is most successful in encouraging health-related behaviors, and your perceived susceptibility. So for smoking, do you believe that, oh, there's no way in hell I'll ever get lung cancer? Well, in that case, you feel maybe a lost frame isn't going to really work on you because you feel like, hey, I'm Superman. I will never be impacted through smoking. So the impact of framing can be influenced by these two factors. There's others as well, but we're focusing on perceived effectiveness and perceived susceptibility. Now let's look at an empirical example of message framing, specifically a sunblock experiment. Remember, everyone, wear that sunblock. It is hot as shit. As a side note, UV rays, that scale of like 0 to 10. Last year, I saw 11, and then I saw even beyond that, it just said extreme, and it was just like stay out of the sun. And I tried to hike in that, and I about had a mental breakdown. But back to our sunblock study here, we have Wang from 2012 who examined how perceived effectiveness of sun safety behaviors and perceived susceptibility to skin cancer can moderate message framing effects. So we have the effectiveness of a sunblock and the perceived susceptibility to skin cancer. And how does that impact the effects of message framing? This refers to the extent at which a particular prevention behavior is effective for preventing the undesirable health outcome. The authors hypothesize that greater perceived effectiveness reduces the perception of risk and thus makes a gain frame more persuasive. Low perceived effectiveness increases the perception of risk and thus makes a loss frame more persuasive. And so basically the idea here, this thought process is that if you perceive sunblock to be awesome, aka it's like very effective. Well, if you believe it's very effective, that means that you're consequently going to believe that your perception of risk is going to decrease if you use sunblock. Because again, you believe sunblock is really amazing. Thus, because you think sunblock is amazing and it reduces your risk of developing skin cancer, the authors hypothesize that a gain frame is more persuasive in those type of people, those people with perceived a high effectiveness of sunblock, to use sunblock because they believe it's going to be effective. So they want to hear information of how it's effective. So, for example, the authors said, you don't look red, you don't get itchiness, you don't get sunburns, no pain, no hurting, you're gaining all of these things. You look hot, whatever. You're no wrinkles forever. You're gaining something. So the person who already believes sunblock is effective. They're basically kind of looking for reasons to support that frame, and thus a gain frame is more persuasive in stimulating or the use of sunblock. And conversely, the authors hypothesize that if you believe sunblock is crap, it has low effectiveness, this is going to increase the perception of risk theoretically, because it's like, oh, sunblock sucks. Now, great. Now I'm at risk for like wrinkles and cancer and looking red and getting blisters. So therefore, a loss frame is more perceptive. So there are costs associated with not using sunblock. So even though you don't think it's effective, there's going to be some costs that you should that you need to take into consideration, and thus theoretically motivate you to use sunblock. So you're going to get blisters, you're going to be in pain, you're going to get sunburn, you're going to be red, you're going to be itchy, you're going to be irritated. So to measure participants' views on how effective they thought sunblock was, they administered a set of questions. One of the questions included wearing sunscreen when in the sun is effective in preventing skin cancer on a 7-point Likert scale ranging from 1, that is strongly disagree, to 7, strongly agree. Researchers also measured perception of risk by asking some of the following questions. That is, my chance of developing skin cancer is slim. I am worried about developing skin cancer later in life. And the possibility of developing skin cancer worries me. Lost frame messages were more effective when perceived effectiveness was low, while the gain frame message was more effective when perceived effectiveness was higher than it was lower. The intention to use sunscreen was influenced by the perceived effectiveness of wearing sunscreen, but not by the framing condition or perceived susceptibility to skin cancer. That had a low effect size. So basically what these researchers found was that actually it was the effectiveness of the treatment, in this case sunscreen, that was most predictive of wearing sunscreen. Kind of straightforward, not the framing condition or perceived susceptibility to skin cancer. So kind of like a lot of these like cognitive, like reframing things. Sometimes there's a significant results, but often low effect sizes. And like all these kind of things we talked about throughout this class, it's not changing health-related behaviors are not as simple as like CBT or something, like cognitively think about it differently kind of thing here. So it could be one method is for sunblock use, according to this research. Well, of course, only this one finding could be increasing health literacy. That is the understanding that sunblock is effective in preventing skin cancer and whatever other else like superficial thing you want to do or health related outcome you want to focus on. McInnes and Hugland in 2011 examined the readability of information about various health conditions online, aka how easily read information is. On average, health information on the internet has a readability suitable for around US grade 12, while average in the US varies, but around 8th, 9th grade, depending on the research. And what the researchers concluded was information dissemination alone is insufficient. Information must be understood by its intended recipients. So basically, this researchers argued and found was that just pumping information online is not sufficient to changing health-related behaviors. The patients, people in general, have to be able to read and understand the information to be able to act on it. So kind of straightforward. And this is really kind of getting at also making sure that the information you provided are interpretable to non-kind of experts in your field, and to be aware of kind of literacy rates within a given context, and thus kind of using potential different ways of communicating to people, which they can better understand given their contextual circumstances. Which naturally leads us to health literacy. And what is it? Early definitions of health literacy focus on the applications of literacy skills, that is, reading and numeracy, to understand and use information to enable individuals to function in healthcare settings. Later definitions expanded the concepts to include social skills and application of these skills to include the ability to access information to promote and maintain health. So we kind of had this basic definition of just like, do you understand what is being told to you? And can you use that information to engage in whatever intervention, medication, exercise, whatever. However, later definitions, kind of much more taking kind of a patient empowerment approach. The construct was reimagined and re-theorized as including kind of social skills and also kind of the ability to promote health-related behavior. So maybe a little more advocacy, the development of social skills, that is understanding what follow-up questions to ask healthcare professionals so you can engage in a higher degree of dialogue. So rather than just like using information, reading it, kind of being able to interpret it on some level, and then moving that to then using that interpretation to engage in dialogue and potential like promotion and advocacy of your own health and maybe your community's health as well. As stated, more recent definitions incorporate ideas from health promotion and patient empowerment to include evaluation and communication skills to enable people to make informed decisions, increase control, and take responsibility for health in various contexts. For our purposes, we will draw on the World Health Organization's 2015 definition. Quote, the personal characteristics and social resources needed for individuals and communities to access, understand, appraise, and use information and services to make decisions about health. A national assessment of adult literacy in 2003 showed that 77 million people in the U.S. had basic or below basic health literacy, more than 1/3 of the population. While many European states also have similar levels of health illiteracy, according to this 2003 study. So, as already reviewed here, kind of reconceptualize health literacy as kind of an empowerment wherein patients can use the information that they learn to kind of take control of their lives and maybe engage in community work to take control of the community, take responsibility across various contexts. So, learning information and then applying it to the real world, and then kind of maybe attempting to adjust their own personal health habits and maybe the health status of their community or whatever by, I don't know, creating a park or whatever, or something along those lines. Or increase vaccination services at schools or something like that. Nutbeam in 2000 categorized health literacy into 3 levels. The first, functional health literacy. This refers to basic reading, writing, and number skills that enable individuals to function effectively in healthcare settings. Activities associated with this level of health literacy often involve communication of health information to improve patient knowledge. Some examples include leaflets, websites, and other available media. So kind of straightforward here. This is functional health literacy, bare minimum kind of situation here. Do you understand the forms you're completing? Do you understand the instructions of the treatment you're receiving? Are you able to kind of navigate those kind of basic requirements of healthcare related forms and adherence to interventions? And this can include typical just generalization like leaflets, basic FAQ, website pages, stuff like that. Just kind of getting what you need to semi-effectively operate in a healthcare setting. Our next categorical level is interactive health literacy. This refers to the development of personal skills to improve personal capacity to act independently based on knowledge, focuses on improving motivation and self-confidence to act upon the advice received. That is self-efficacy, include efficacy, I should say, include tailored health communication, community self-health, and social support groups. So kind of stopping here for a second here, interactive. So I'm improving my social communication skills and also kind of using those skills to maybe ask like follow-up questions. But ultimately, I'm trying to use my personal developed skills to build confidence in myself. So I now understand something. I kind of feel like I have a little social swag or something like that, or kind of just increase the belief in yourself that you can accomplish your goal-related goals, aka self-efficacy. In return, that combination of believing in yourself that you can accomplish goals, increasing your social skills, your personal skills, and acting independently on that knowledge, that can take the form of just general health communication, being in some kind of social support group. So again, I'm interacting with people. We're trading knowledge. It's interactive in nature. We're building up our motivation and confidence to act upon whatever intervention or lifestyle change that we're working for. And then we have critical health literacy, refers to the ability to critically evaluate and use information to actively participate in healthcare, include cognitive and social skills development and capacity building to influence the wider social health determinants. So critical lens here. So the idea is, okay, yes, you have the information, you can act on it, you have these personal skills, maybe you're confident, maybe not all those things at the same time, but now you're also like, okay, well, this is insufficient. Or can we think of a way to design the world differently to decrease negative health outcomes? So really looking at those social health determinants, those determinants of health, building a community, building your country, whatever. So advocating, stuff like that. So much more like advocacy, future-oriented, while problem-solving in the immediate kind of thing. So thinking personal, community, and like structural is kind of the idea of critical health literacy. Let's review some research on health literacy. Associations between health literacy, access to healthcare, and health outcomes have been identified. Berkman in 2011 showed how poor health literacy was associated with higher hospitalization rates, greater use of emergency care, and poor access to immunization and screening services. People with inadequate health literacy were less able to take medications appropriately and interpret labels. Among elderly persons, limited health literacy was associated with poor overall health and high mortality. So just kind of circling back around to those levels of health literacy. If you don't even have kind of basic functioning health literacy, you're going to have a difficult time reading medication labels, for example. And thus, even if you want to and intend to adhere to an intervention, you're unable to. Maybe you take too much, maybe you take too little, maybe you're fluctuating, and this can return, can increase the probability of having to go to the emergency room. And it's especially risky among elderly persons who are obviously, in general, compared to younger people, more vulnerable to death from kind of like incorrect or unstable kind of medication use. You can also imagine some kind of like symptom happening to you and thinking, yeah, that doesn't really matter, but it actually does matter. And it's like on like the list of like, if you have this symptom, make sure you tell your doctor or something along those lines. So if that person has very low levels of health literacy, maybe they don't fully understand it, they can't read it, whatever. And thus some important information is not communicated to their healthcare professional. And then they're at greater risk of a future emergency care visit. Continuing on to other research on health literacy, O. Chang in 2013 examined the experience of Black African migrant families in accessing health promotion services using self-administered questionnaires in Arabic, English, French, and Swahili. The researcher found that limited literacy and proficiency in English were perceived barriers to assessing services among migrant families. Because of communication difficulties with healthcare professionals, the participants felt reluctant to seek health promotion information and support in the first place. So this was qualitative, or included qualitative of information or data collected from the participants, and I will read some of what the participants reported. And these are all quotes. So, quote, I would suggest to have at least having translation and interpretation services in Arabic, French, and Swahili because these participants are spoken in different parts of Africa, stated a Somali female participant. I try my best to speak in English so that I do not cause any problems to the doctors and nurses. But I find it difficult to ask questions and to clearly express what I'm really looking for or to ask advice about my health, a Burundi male participant stated. And finally, it is important to have a link worker from our community who is well trained in the healthcare system, said an Angola male. One thing that would help is to have a link worker to work with members of the community giving advice, stated a Togolese female participant. So here we have patients attempting to use healthcare services. However, they are running into barriers. And this research found that kind of the proficiency in English acting as a barrier to accessing services. So although they can speak English, they're not as proficient as their native language. So when kind of trying to communicate their symptoms and kind of like their medical condition, they are not able to kind of elaborate and elucidate themselves in terms and ways that they could in their native languages. Thus, these kind of suggestions of translators or some kind of interpretation or kind of like embedding healthcare professionals within their community. So this is kind of this link worker here. So having a connection embedded in the community, working with the community, and then those sets of link workers then reporting to some larger healthcare facility. So you kind of have like in real time kind of information about health concerns in the community, perceived barriers and something along those lines. And then thus you have this kind of interactive, culturally sensitive, and theoretically highly ecologically valid transmission of information between patients and the general population and healthcare professionals. Improving HCP communication skills. To enable patients to make informed choices, HCPs need to take steps to communicate in a manner that patients can understand. Prothero and Rollins argued in 2013 that HCPs need to adapt their communication techniques to take into account the patient's differing levels of health literacy. This, as we already viewed, recognizing the rates, the proficiency of health literacy within a country. You can like it, you don't like it, but the reality exists. So until that reality changes, the argument is adapt your communication techniques to increase adherence or trust and ultimately improve health outcomes within these patients. Oliveira in 2015 found that communication training for clinicians can improve patient satisfaction, especially in reducing pain in primary care and rehabilitation. Some suggestions included slowing down. Spend some time talking with patients using plain language. Visual aids can help to enhance understanding and recall. Show or draw pictures. Simple line drawings and cartoons will suffice. Other suggestions included limiting the amount of information provided and repeat it. This is particularly important for patients with limited literacy skills, since health literacy can significantly influence people's ability to remember verbal instructions and to recall information. Create a shame-free environment. Some patients may feel embarrassed to share their literacy difficulties because of stigma. Important for HCPs to encourage patients to ask questions. Ask Me 3TM program can be a useful guide for patients and HCPs. Patients are encouraged to ask HCPs 3 questions. What is my problem? What do I need to do? And why is it important for me to do this? So we have communication training possibilities, which are really training, standardized almost in some ways, communication, but obviously applied to a healthcare setting. So kind of slowing down, not just like go, like, a 10-second explanation with very little specifics and then kind of moving on, but kind of slowing down the process of explaining something and making sure that a person understands it and can act on the information provided. This can include repeating yourself, which, as you probably noticed by now, I do that often. And this is because people will understand things something will click when you explain the same information in multiple different ways or repeating yourself. It's just kind of like raw repetition and kind of different viewpoints of the same general information. And then we have the shame-free environment. So this could be like the idea that, okay, this person understands that they don't fully get it, but they are less likely to communicate their difficulty in understanding something because they'll feel stigmatized. So kind of the idea is like, oh, I should know this information. I don't. Oh, I look like dumb. And this person's going to think less of me. And then maybe they'll treat me differently, something kind of along those lines. Promoting individual and community capabilities. Health promotion requires the development of skills necessary to enable individuals and communities to take control over the determinants of health. A word of caution, however, some authors argue. Promoting health literacy does not necessarily lead to patient empowerment. Schultz and Nakamoto in 2013 argued that although health literacy and empowerment may be related, they are distinct concepts, and one may not necessarily lead to the other. That is, just improving health literacy alone does not necessarily mean that you have empowered people to kind of like take control of their community and address all of these kind of systematic kind of like injustices. Although health literacy may be required to engage in that fully, possibly. However, just being health literate in itself does not mean you're all of a sudden going to be kind of an advocate and trying to change the circumstances surrounding social determinants of health. But even beyond the kind of big structural social determinants of health, the authors argue, that is Schultz and Nakamoto, that high levels of health literacy without improving patient empowerment can increase probability of patients becoming overly dependent on their HCPs. On the other hand, improving patient empowerment without corresponding improvements in health literacy potentially can increase probability of dangerous self-management among patients. So kind of the idea of the first bullet point here is that maybe literacy has increased, but the person does not feel that they can act. They're not empowered. They're not self-sufficient, or at least like collectively sufficient within their community. And therefore, they're going to be over-reliant on the HCPs and unable to kind of act in their daily lives, which, you can't always call every second your HCP. You need kind of to be able to act and make kind of decision-making engage in a decision-making process in a relatively confident way. While on the other hand, having high degrees of empowerment, confidence, belief that you can accomplish your goals, while at the same time having very low levels of health literacy can be dangerous because you believe you can do anything, but you actually don't know shit. So therefore, maybe engage in kind of very harmful pseudoscientific treatments, for example, that you read online or something like that. When aiming to help patients become effective self-managers of health, interventions need to encompass methods for improving both health literacy and empowerment. Our authors, Schultz and Nakamoto in 2013, argue only these two in combination can ensure patients have the knowledge, skills, and confidence to use appropriate resources effectively to promote health and maintain their health. So basically, the authors are arguing that if you're delulu, but also ignorant, that is risky. If you are have low confidence but a high level of, or some high level of literacy, that is also potentially negative because, again, you can't really act in your own life. Therefore, you need some combination of both of these, and thus that is what we should be going for. Creative methods can also be used to improve health communication, such as tech, mass media channels, radio, theater, and storybooks. Contemporary healthcare systems often rely on overly complex processes that can be tedious to operate, even to those with high levels of health literacy. So this is not uncommon. If you have not had the pleasure of operating within a hospital or engaging with a healthcare facility and dealing with insurance, those things kind of pain in the ass and quite complicated. So even as somebody with a PhD and me, sitting here reading hours of trying to figure this out, well, most people, I would say, don't have my level of educational background and also don't have hours of blow reading shit. So it's no secret that our healthcare system can be overly complex. Thus, kind of reducing that complexity can be beneficial in breaking news. And wrapping it up with the World Health Organization Healthy Cities Initiatives. These professionals argue that urbanization offers many opportunities for employment and access to better public services. The rapid and unplanned growth also poses major health risks. In urban settings, determinants of health are linked to social, demographic, economic, and geographic factors that create complex vulnerabilities that affect healthcare exposure, health behaviors, access to healthcare, and health status. A long-term international initiative that aims to create health supportive environments through comprehensive local strategies for health protection and sustained development is indeed the World Health Organization's Healthy Cities Initiative. They argue that this initiative capitalizes on community participations, intersectoral partnerships, and participant equity to ensure that health is placed high on the agenda of key decision makers. The success of a healthy city is therefore dependent on the political, economic, and social will to improve the local environments to promote health. So in all that jargony English, what they're basically saying is, yes, urbanization, we love it, sure. Kind of you have more job opportunities, maybe better public services. You got a bunch of people close together, so maybe you have a opportunity to build some kind of community. However, there are risks if you just like let this thing go like ham without any kind of like popular impulse input, in particular for kind of health-related outcomes, because as reviewed, social, demographic, economic, geographical factors predict health-related outcomes. Therefore, this kind of like initiative is kind of designed to create some kind of partnership between residents within the community, whatever stakeholders is the buzzword. So whatever businesses or whatever politicians or whatever it is, NGOs that are in the community, all those people come together to design a theoretically beautiful, healthy city. Because again, we understand social determinants of health and all that jazz. So thus, a healthy city will involve be dependent on kind of the political, economic, social, cultural conditions of a particular local environment is the idea. Theoretically, that social determinants of health, not really controversial. This is consensus. Now, what to do about it if this initiative is going to do anything? Who knows? It's up to your theoretical perspective on these kind of things. All right. So with all that said, thank you so much for listening, and I hope you have a great week. Goodbye.